are governments actually listening to those lessons? Or are those lessons being ignored? So uh, let us, of course, I think already Dr. Antony has talked about this in great detail, but I'll just mention that while COVID-19 in India has been an unprecedented tragedy, it's also a saga of major misgovernance. And I think there are so many examples, probably one could make the entire presentation just on that topic. So I will not go into all the different aspects of misgovernance, especially related to the second wave. But I'll just mention one which was quite striking, and the way in which the Kumbh Mela in Haridwar was preponed by 1 year. It was scheduled to take place in 2022. It takes place once in every 12 years. The last one was in 2010, but it was preponed by 1 year to take place in the middle or in the of the COVID entire pandemic, and placed at the beginning of the second wave, when the second wave was already emerging. And as we know, something like 70 lakh people participated in this Kumbh Mela because of the way in which the government allowed it to and encouraged it, and in fact preponed it to happen. And because of this, all these people bathing in the Ganga, we know, what happened at that time. And after that, then many more people also bathed in the Ganga, especially in Uttar Pradesh and Bihar. But that bathing was of a slightly different variety. It was because of the huge spread of the COVID pandemic in these northern states, and where people did not even have the fuel to burn the dead bodies of the large numbers of COVID patients. And they had to dispose of the bodies in the Ganga River. So I think that this entire, the way in which the pandemic has unfolded, especially in the second wave, must give everybody, every thinking person in this country, uh, you know, it must be provoked to introspect. And the way in which, the funeral pyres were burning day and night in some of the cities and some of the areas, especially in northern India, is a stark contrast to what has been talked about Kerala just now. And I think that we really need to see that something different could have been done. And today, even according to the official figures, more than 4 lakh people, more than 400,000 people have died of COVID in this country, and the actual figures are probably much higher. So without going into details of this aspect, I'll now come to some comparison between four major states of India, which have seen among the largest numbers of cases. And why have COVID death rates been higher in certain states compared to other states? I'm taking four states: Kerala, Karnataka, Gujarat, and Maharashtra. And these four states have all seen large numbers of COVID cases. They are all four states are at a similar level of per capita income and per capita GSDP. I'll show that in the next slide. So in one very major variable which influences various health outcomes is, of course, per capita income. That is similar, but the COVID outcomes have been very, very different. And of course, it has been mentioned that even in Kerala there has been probably some underreporting of COVID deaths. But even if we apply the same factor of underreporting to all the four states, it will not change these ratios. Suppose we double all of these for all the four states, even then, we would see that the COVID case fatality rate in Maharashtra is more than 4 times higher than in Kerala, which means that if Maharashtra had a similar COVID case fatality rate as Kerala, 3 out of 4 people who have died in Maharashtra would not have died of COVID. Of course, you can say that there are many other factors: levels of testing, reliability of death reporting, etc. So I accept that this is a rather not a very precise indicator, but it's the one of the very major indicators which we have available. As I mentioned, all these four states have similar per capita GSDP. So socioeconomic differences are not a major factor, at least in the aggregate sense. So we are not comparing, Delhi with Bihar or Goa with, Madhya Pradesh. We are comparing four states which have similar levels of per capita incomes. And then let us see then what are the factors which are responsible for these stark major differences in COVID fatality. Now let's look how many government doctors are there per lakh population. Maharashtra 6, Karnataka, Gujarat 8 to 9, Kerala 15. A 2.5 times difference in the numbers of government doctors. So the public health system is clearly stronger. Percentage of hospitalization in public health system. Maharashtra 22, Karnataka, Gujarat 27, 31, Kerala 38. Almost twice as high as Maharashtra. So clearly many more people are accessing public health services in Kerala compared to Maharashtra. Per capita public health expenditure in rupees. Maharashtra 1266, Karnataka, Gujarat 1500 to 1600, Kerala almost 2000. So almost almost 1.5 times higher per capita public health expenditures. And these are large states. I have not taken states like Delhi or Goa, smaller states where per capita expenditures tend to be higher because of other reasons also. But we are very clearly seeing a trend. Now we can have a further discussion on this, but I think that there is a pattern. Per capita health, so that is one, and public health expenditures as a proportion of the GSDP. Maharashtra 0.6, Karnataka, Gujarat around 0.7, Kerala 0.9. Clearly 1.5 times higher in proportion. So by all these 4-5 parameters, we can see that the levels of functionality, the level of resources, the level of utilization of public health services is a clear determinant which seems to be associated with better COVID outcomes. So across multiple health system indicators, weaker public health systems and higher degree of privatization of healthcare are associated with worse COVID outcomes. Let me also mention here that numbers of total hospital beds per thousand population are actually higher in Maharashtra and Karnataka compared to Kerala. So we are talking about public hospital beds being higher in Kerala. So actually, total hospital beds, including the private sector beds, may be in fact higher in some of these states. Compared, at least in Karnataka, it is higher than Kerala. So it's obviously privatization which is the problem. It's not just the issue of availability of beds in general. Even if there are large number of beds available in the private sector, that does not translate into availability of adequate health care in an epidemic. This is a very important point which I think needs to be emphasized. Weak public systems and high levels of privatization are injurious to health. If there is one lesson from the COVID epidemic that we need to learn, it is probably this. And which means that healthcare must be a public good and not a commodity. And obviously, what we already knew in the health movement and also in the public health circles, that public health systems have a vital and irreplaceable role. And unregulated private healthcare leads to not just market failure, but to market disaster. And therefore, it needs to be regulated. The much touted health insurance schemes, as we saw the recent data, especially in the northern states, where the PMJY was the main form in which it operated, they have failed to serve people in times of crisis. In some of the southern states, of course, which had pre-existing schemes, they performed somewhat better. But even in states like Maharashtra, we see that the health insurance schemes have not really been able to serve large numbers of patients who required care in this situation. One positive lesson is that state governments can act to regulate private healthcare. When it comes to this kind of a situation, the political will to regulate rates, for example, which was non-existent despite the health movement and many health experts having raised this issue, it actually materialized overnight in the epidemic. So governments can act, especially, and we have seen that state governments have acted, but many of these actions have been kind of piecemeal, ad hoc, temporary in nature. And because the legal instruments were not available, therefore, they have been somewhat inadequate. And which means that more effective legal and operational frameworks for regulation of private healthcare are absolutely essential. Now, regarding private healthcare, what are some of the things that could have been done? Now, as we know, during the COVID epidemic, around 15 Indian state governments invoked the National Disaster Management Act, in some cases the Epidemic Diseases Act, and they stepped in and regulated rates for COVID treatment in private hospitals. This was reasonably remarkable given the earlier history, but it's all done by state governments. The National Human Rights Commission issued 2 sets of detailed health rights advisories especially focusing on observance of the patient's rights charter, rate capping, grievance redressal mechanisms, etc. So this is what has been done by the state government, by the NHRC. But if you look at the central government, in this entire period, not a single step has been taken to ensure implementation of the Clinical Establishments Act, which is 11 years old and which applies to 11 states in this country. And nor has there been any central initiative regarding regulation of private hospitals. Whatever has been done by state governments. I think this is something we need to take note of. There was an option of taking over private hospital beds, which was mentioned regarding Kerala, where 50% of the beds were taken over. Some other states did it on some scale. That is true, but this could have been exercised. This option could have been exercised on a larger scale. And of course, lot of irrational care in the private sector in the COVID situation. The whole remdesivir scare panic, which was created, and black marketing or inflated prices of remdesivir and tocilizumab and so on, and also overuse of medicines like steroids. And you know what happens when diabetic COVID patients are also given high doses of steroids. Now we are seeing the effects in terms of mucormycosis and so on. So treatment protocols, I mean, ICMR, of course, adopted certain protocols along with AIMS, but those were not actually, regulated in the private sector. So these are many other things which could have been done and still can be done regarding the private healthcare sector, in the COVID situation. And therefore, we need to start looking at that there are two different ways in which public engagement can take place with the private healthcare sector. With a huge private healthcare sector in India and in most states, of course, there has to be a public engagement with this large scale resource. But on one hand, what we have is market-based engagement, which is there in most of the PPPs and health insurance schemes, where it's kind of optional. If they want to, they can get involved. Market rates remain dominant throughout the sector. Even when the patient enters the hospital, most other people are paying for services. There's a larger, there's no rationalization of treatment practices. Admissions control remains in the hands of the private hospital, and there's very weak social accountability. This is the kind of engagement that we have seen until now in terms of PPPs and health insurance. This health is obviously not working. Definitely not in the COVID situation. So in this COVID situation, we have seen these interim arrangements like rate capping and temporary takeover of some hospital beds, which have moved a little bit more in the direction of public health engagement. But that needs to move even further towards mandatory involvement. It's not optional. All hospitals have to, have to have the rates regulated. There has to be a free service environment where everybody coming to that facility actually gets free care. There has to be a rationalization of treatment practices in the private sector, which is under public regulation. And the control of admissions has to shift to the public system rather than leaving it to the free will of the private management. And it has to be universal with inclusion and accountability. And that means universal healthcare, public regulation, and harnessing of private sector resources. This is the model which we now have to push in the COVID and post-COVID situation. It's very clear that the market-based arrangements have failed. They have not worked. What we need is much more public-centered models. Now, I'd just like to draw your attention to another aspect which has not been sufficiently perhaps highlighted in the COVID situation. Sati and some other organizations have done some research on this: corporatization and financialization of healthcare, a huge phenomenon in India, especially in the last 2 decades. Today, 5 large hospital chains, they have grown by almost 80% in a 5-year period in the last decade. And these names: Apollo, Fortis, Narayana, Max. And financialization, accompanying corporatization, with penetration of multinational finance on a large scale and pushing these hospitals to maximize generation of revenue, pursue targets, pushing doctors to pursue clinical targets, and inflating the prices of healthcare in a major way. And therefore, many of the top corporate hospital chains in our country like Fortis, Medanta, Apollo are now primarily owned or taken over by foreign investors. We should not forget this. Foreign investment in the hospital sector in India has increased 100 times. Note the figure again: 100 times in just a decade, from 2001 to 2013-14. There's a huge, influx of foreign capital in the Indian healthcare sector, which demands its pound of flesh in terms of maximization of profit, and which is not good for public health. However, we are seeing, despite all this, this entire experience, the document by the Niti Aayog on investment opportunities in India's healthcare sector. And after reading this document, I think some of us have been wondering that after the worst pandemic in nearly a century, with this huge experience of overcharging, irrational care by private hospitals, there's not a single sentence in this entire report which mentions the negative behaviors of unregulated private healthcare in India. I mean, whether it is invisible or it has been forgotten, one doesn't know. And the report presents the COVID epidemic as a great business opportunity, which requires even more foreign investment, even more corporatization, even more privatization of healthcare. And in the entire report, at least I could not find even a single mention of the word regulation regarding the private healthcare sector. So we are talking about lessons of the COVID epidemic. I would suggest that all of us need to think, are these lessons so difficult to learn? Is it difficult to understand that privatization of healthcare is not favorable to public health, or is there some other factor which is preventing these lessons from being learned? These are just a few excerpts from this document. The COVID-19 pandemic has presented several opportunities, and all these factors make India's healthcare industry ripe for investment. Means more privatization, more private and foreign capital coming in, expansion of private players to tier 2 and tier 3 locations, attractive investment opportunity. This is from the foreword of this document. And then further it says that Niti Aayog is proposing a model which enables the upgradation of district hospitals to medical college using the viability gap funding, which is basically a PPP arrangement by which the government, either central or state government, will give funds to private actors to run public hospitals and handing over public hospitals like say district hospitals to private actors to operate, and then they will charge fees for a large proportion of patients, and maybe they'll be supposed to give you some free care to some proportion of patients. But as we know, these arrangements almost never work well, and the concessionaire, which means the private operator, will then operate the district hospital. This is what is written in this document. Now I think we need to reflect, and this is not just written in a document. This uh, this actually entire move of further privatization of healthcare has started. And from Chhattisgarh, we have this. अब गांव में भी बनेंगे private अस्पताल. This is the Chief Minister of Kerala. It's being touted as a great achievement. I mean, until now, healthcare was privatized in cities. Now it will be further privatized even in rural areas. I don't see how this is an achievement or how this is a positive policy direction. In Chhattisgarh, again, activists have started, protesting on this and raising this issue. I think this will be a disastrous direction. It needs to be stopped immediately if we want to learn anything from the COVID pandemic. I'll just
Dr. Shukla,
find,
I beg
yeah,
your pardon. I
yeah.
beg your pardon because we are really running out of time and we have Dr. Shah waiting for us. I
Okay.
think we have exceeded your 15 minutes.
Okay. So I'll end it by basically saying that this is the change we must see in our health systems before COVID. And even now, the profit logic has been dominant and the social logic has been weak. After COVID, this must be reversed. The social logic must become dominant in the entire health sector. The profit logic must be controlled. And we don't want a return to the old normal. We want a reconstruction to a public centered universal system, not a return to the privatized and commercialized healthcare system. And that is why we must block all moves for further privatization of healthcare and learn the lessons from the COVID epidemic of strengthening public health systems and expanding regulation of the private sector. Thank you.